Thank you very much. I'd just like to thank the Deborah International for the invitation to speak today. Dentistry is a very interesting component of EB. It sort of gets forgotten because it gets hidden behind the lips. And so what I will produce today is give you some case studies and also give you an idea of what the guidelines are about. Firstly and most importantly is the aspects of dental care. So it's what we should aim to do as dentists is to provide dental care that prevents the development of dental disease and minimises the potential for EB complications. To provide treatment strategies, provide optimum dental outcomes, provide treatment strategies that may enhance medical procedures, and we should consider the expectations of the patients and families. So for us as clinicians, the factors are, and I think the basis of this whole day was sort of set up by Humphrey this morning, talking about what's important, is that we as clinicians should understand EB, understand the signs and the symptoms that may arise, understand the treatment risks and complications, and be aware of experience of others in the area, and be aware of resource information such as Deborah International. So within the scope of dentistry, you can break it down, if you're wanting to look at the clinical status, you break it down simply into the four main groups. That's EB simplex, junctional EB, and EB dystrophic dominant and Kindler EB. Each of those have different dental characteristics that provide us with significantly different dental problems. The oral manifestations of epidermolysis bullosa spectrum is that we see as oral blistering, oral scarring, microstomia, enamel defects and ankyloglossia. There has now been established a score system called the Epidermolysis bullosa oropharyngeal severity index, where you can score each of these indices and therefore get a score related to the severity of that individual. And that's in the Journal of the American Academy of Dermatology. If we look at EB simplex, the genes associated with EB simplex all cause interepidermal cleavage of the skin, but not expressed in the oral mucosa. The oral blistering occurs secondary to trauma tissues and sometimes usually tends to heal. Localised and generalised blistering will occur, but heal without scarring. Dowling-Meara variant can display some oral scarring, but you get normal dental enamel and saliva flow. Junctional EB provides some other different concepts. The protein transcribed from the genes associated with junctional EB is important in the epithelial cell adhesion and developing tooth bud. So in junctional EB, you can get a variant which causes a problem with dental development called amelogenesis imperfecta. You get oral blistering in both groups. You get enamel defects occur in both groups. Microstomia occurs, particularly in the Hurlitz type EB. You have an increased risk of dental caries reported in the literature. Saliva flow seems normal in most individuals with the junctional EB subtypes. Dystrophic EB, the gene that mutates in dystrophic EB is not expressed by the ameloblast. The ameloblast is the cell that forms the dental enamel in teeth. So the consequence is there that you're not getting any defect in dental development. They have oral blistering and scarring, and the recessive EB can have oral scarring and associated with ankyloglossia and the loss of the vestibular architecture. The vestibule is if you put your finger in your mouth and you run it around the inside, you'll find there's a gap above the teeth. And we'll show you a slide later to show where that just diminishes and is basically non-existent. Due to changed anatomy, there's a reduced ability to clear food and consequently increased oral clearance time. And again, apparently normal salivary flow rates. But there's been no studies on salivary flow rates, and anecdotally, I think there is a reduction. Kindler EB, type E, you get oral blistering, particularly in neonates, which can be severe and cause difficulties with feeding. The severity reduces with age. The Kindler ones have an increased ability to develop periodontal or gum disease during teenage years, and this is because the protein expressed by the epithelium that attaches the oral mucosa to the tooth is consequently at risk and causes periodontal conditions. and obviously oral blistering, scarring and microstomia occur. So the oral complications that we would get is changed. Obviously there's a change in oral anatomy. You get microstomia, which is basically the mouth gets smaller and constricts down, and in all dimensions it is reduced. Ankyloglossia is basically you're getting a tongue tie, that the tongue gets tethered to the floor of the mouth. You get diminished oral function, you get reduced salivary flow, and obviously you can get changes in oral pathology. You can see here in this young child or young girl that the mouth looks exceptionally dry. She's got increased incidence of dental caries, and she also has microstomia. So the concern is there with that child. What are you going to do? If we're looking at tongue tie, it occurs, and the problem that you get here is there's a study done by Susan Kramer from Chile, and you can see here's the example of tongue tie where the tongue is tethered. The other thing that's important is not tethered in only the anterior-posterior movement, but it doesn't get lateral movement. So it means that if you're sitting there and you've got food stuck down the corner of your mouth, you can flick your tongue around and suck it out, whereas these kids can't. It sticks there. So therefore that places, because they get poor oral clearance, if they're having a lot of high carbohydrate in their diet, they are at high risk of getting dental caries. You can see in this middle slide here, these are the recessive dystrophic EB kids, and you can see they have a lot of tongue movement. And hopefully we're going to run a study in Melbourne looking at our population to see what tongue movements we have there as well. You can see here is what we were talking about is the loss of vestibular depth. We can't see around the corner. You can see here that there is no sulcus, that basically the inside of the upper lip is joined just above the gum line. Again, it provides significant issues for oral care, and it makes it very, very difficult to clean. Also, in these instances, it makes it difficult to clean because the tissue gets traumatised by a toothbrush, and therefore you get possible blistering and scarring. So salivary flow rates. Studies have shown that there's not a reduction in salivary flow, but looking in mouths and seeing how sometimes they look particularly dry, I have a concern. So we did a Lucas survey of 4 patients and got them to provide a saliva sample over a period of time, which is basically they chew a piece of latex or chewing gum and spit into a vial, and it gets all frothy, and my nurses say that's revolting and walk out of the room. But basically it found that if you're looking at a normal salivary flow rate, it seemed to be reduced. I think the reason would be is particularly in the submandibular area when they're getting tongue adhesions, is that it's blocking their submandibular glands and their sublingual glands. Enamel defects. Amelogenesis imperfecta is the broad classification of what happens to dental development when it's forming. You can see here in this young guy, that is the way the tooth erupts. It is all brown, and therefore, how do you treat that? Because that is an aesthetic issue. You have many issues in all kids with amelogenesis imperfecta, whether they have EB or not, and one is aesthetics. You don't want to smile with teeth like that. So nowadays you can place like a little using dental resin materials or make it look white. The older they get, you can use things like porcelain veneers. And here's a series of cases of a young girl who you can see over on here, particularly there where you see the enamel is very poorly formed. In her teenage years, she had some resin placed over them, but that tends to break down. And now she has had some porcelain veneers placed on her. And she is a young girl with junctional EB. Delightful kid. And now she is really, really happy. A very nice aesthetic smile. Microstomia is an issue for a number of reasons. It decreases the ability for us as clinicians to get and work in a child's mouth. It also makes it difficult to them to get intubated because the anaesthetist has a very small area to access, and they're not going to put down nasal intubations. They'll put oral tubes down because it's easier. So therefore, suddenly you've got no room to work in. So what do you do? There's two possibilities really. There's a non-surgical intervention where you can use, which they show on the guidelines, these sort of toppy things that people put in there and screw to open up and hold the mouth wide and open. I don't know exactly what that thing there is. If people on that side, that's that metal thing that looks like it was invented in the Spanish Inquisition. I'm not sure how it even really works, but it was in the guidelines. So you can use that. You can use orthodontic appliances. There's a thing called, a terabyte, which they use a lot in burns patients, and people have had jaw surgery, which you can it's like a little piston thing, and it opens up the jaw. But rarely we have performed at the Children's Hospital for kids who have very reduced thing is we've released the strictures on the corners of their mouth. Now, if you look in the literature, nobody really knows why it occurs. I have no idea why it occurs, but you get that tethering edge on the corner of their mouth here that contracts the mouth and allows them not to open. So over the years, we've done probably half a dozen kids like this where you've basically released those strictures on the corner of your mouth. You're not releasing and doing like a plastic surgery procedure, but you can release the strictures. In recent times, we've been able to use it using a diode laser, and we've got increased. We can open somebody up about 3 to 4 millimetres of extra opening, which makes life a lot easier for everybody, and then you can use some of those other techniques for them to exercise at home to maintain that opening. So you can see there that the opening has increased. The other thing is that looking at quality of life studies, in Susan Kramer's study, is they looked at quality of life, and they found that if you looked at the children who had simplex, they were sometimes concerned about the problems with teeth and gums. Seldom did they have troubles biting or chewing. With the junctional EB, they were always concerned about problems with their teeth and gums, and a lot of that would be related to the aesthetics and their smile, and sometimes they had biting or chewing. The severe generalised recessive EB children often had trouble chewing, seldom were able to swallow comfortably, and that is another reason is it creating accesses, because a lot of these kids have to have continual dilatations, esophageal dilatations, to maintain patency of their esophagus. Seldom were able to get to eat without some form of discomfort. Again, that could be reduced to the tissues being friable and maybe blistering. And one question we had as a group of us talking at lunchtime is what is which we hadn't really thought it through, is that oral ulceration, how much issue does it cause, and what treatment there is apart from putting topical anaesthetic on it. And I was thinking about, Dee was talking about using gentian violet. Well, it's a very simple thing to paint on into the mouth, which they use for a variety of things, but that's a total another side. So if we come now to the guidelines were established in about 2011, and I think they're on the Deborah International website. They were basically put together by a group which was led by a Chilean lady called Susan Kramer, who's published quite a bit on EB and its management. They were basically collected by using the SIGN guidelines, which again, you have a small group of people, you can't really get a complete and accurate, because if you're looking at classification one is you have randomised control studies. Well, how can you have a randomised control study with a group of kids with EB? So a lot of it is based upon case reports, a lot of it's based on professional opinion, and so therefore you get a recommendation as A, B, C or D, which A is the one that's based on randomised control studies, and D is basically on the gathering of like minds, like with the wound project. So what is the basis of the best practice guidelines in dentistry? So basically within the guidelines, they provide oral care for patients with inherited epidermolysis bullosa. It looks at dental treatment, anaesthetic guidelines, and there's a series of appendices about a variety of different things that you can achieve. So with children with EB, most important thing is basically early referral, getting them into your dental clinicals, into the system of seeing a dentist, and the parents being provided with the information to provide preventive components for the children, teach them how to brush their teeth properly without being stressed that they're going to cause oral trauma. Early diagnosis of enamel abnormalities is most important, so that therefore you can therefore plan a program of repair. Early diagnosis of dental caries, because the more advanced the dental caries is, the more difficult it is to treat if you're having to extract teeth in these children. Early diagnosis of tooth crowding and looking at those sorts of things, and looking at whether they do have a lot of oral bullae and ulcerations, and therefore planning and demarcating what those ones are. Preventive strategies are basically at home and professionally. Using things or adjunctive therapies are things like using high-level fluoride toothpaste, chlorhexidine mouthwashes, and being aware of diet. So sometimes there becomes a slight conflict in diet where the nutritionists want the kids to have a lot of carbohydrate to keep them well and going, and the dentist saying you can't have all that starchy stuff because it's going to stick to your teeth and get dental decay. So therefore there has to be a balance in that approach, and also trying to work around the problem of microstomia. Dental treatment can be many things can be done in EB kids. You can do, or individuals. Obviously, preventing cleaning examinations is simple. Restorations, fillings and crowns can be done. They may be difficult to do, but they can be done with care. Orthodontic care. We have done a few kids with recessive dystrophic EB to align their teeth with braces. And there's bits and pieces and adjuncts that you can use to protect the tissue from the braces. Periodontal therapy can be essential. There's some case reports about individuals having implants placed. Oral surgery and tooth extraction can be done in third molars, but it can be done with difficulty. But sometimes you have to electively do that before the access to those areas is minimised. And the most important part about being in theatre is, because you're a dentist and you're working on the head, is that you don't rub and irritate everything and cause a lot of facial blistering. So therefore, it is most important to be able to protect the individual's face from you irritating it with your techniques. And some mothers even have the skill of coming and putting it on themselves. If you're looking at preventive strategies, they must be age-specific. For younger children, then the emphasis on reducing dental decay so that the child develops a pain-free, healthy, aesthetic dentition. For the older patients is to reduce the effects of tooth decay and also gum disease and the ongoing effect of the condition. So in that, you should reduce the consumption of foods containing refined carbohydrate. Use fluoride toothpaste, use the number of remineralising agents, use your manual, or probably is a lot gentler and softer than electric toothbrushes, and most importantly have regular dental reviews. And also the other thing is very aware of what things are. So this is a very brief chart giving you the acidity of a variety of drinks. So if you look at the classic is Coca-Cola, which you can see is down here, or Coke and Pepsi, have a pH or an acidity of 2. Car battery acid has an acidity of 1. So they're very erosive if kids use them a lot and they don't have any protective factors as well. Treatment planning, you have to evaluate everything. And as Humphrey said, be aware, speak of the devil. As you have to be aware of the individual needs and wants and put those into perspective so that therefore your treatment, everything blends in together. And also you have to understand the interrelationship of the medical condition to treatment planning. So anyhow, as you say, individuals with EB are rare and are brave, as we saw on the thing, but they deserve optimal dental care. Thank you very much.